Well, the MCHEP program is really near and dear to my heart. And when I think about MCHEP, I think about data that's used to help women, infants, and families at the state level. And I think it's a really important contribution that the MCHEP program makes to helping people in states.
Using data to improve the lives of women and children. The focus has never been about research just for the sake of research.
My experience working in the Georgia Health Department between 1989 and 1996, during which time I worked closely with Dr. Ginger Floyd, who was head of the Maternal and Child Health Program. I was in epidemiology, she was MCH. But she's the one to whom I provided data, and she's the one who always had a test question: how will your data help Mrs. Jones? And her concern was whether or not the data could be used either to improve policy or improve programs for women and children in the state of Georgia.
Being an MCHEP assignee to me is almost like being an epidemiologist at the bedside. You have an opportunity to work directly with state health departments, to work directly with staff, as well as the families that are affected by certain programs.
I joined the program as an assignee in a state. I was there for 4 years, and then I joined the team at headquarters to gain some experience in Atlanta and to influence the program at a national level.
In the transition between being a Louisiana assignee, Katrina hitting New Orleans and Slidell, where I used to live, and going back to Atlanta as the MCH program team leader.
I was working in the state of Massachusetts on perinatal regionalization. We had to organize 68 hospitals within the state to come together to make some consensus about the most appropriate ways for babies to be cared for in the state.
By improving our understanding of how health and disease develops over their life course, by explaining why some mothers and children are healthy and others are sick, by telling us what's working and what's not, and by constantly reminding us the gap between what is and what can be.
Setting up ongoing resources in the state to continue doing work after I left is one of the things I'm proudest of.
There's a veritable army of people who are looking out for the interests of the health of mothers and infants and children in the United States.
The investment that you do when you improve mothers and children's health is enormous. There is no other time in life where we can have such an impact by addressing pregnant moms and moms with the children through health programs.
It's more than just epidemiology. It's more than just numbers and analysis. It affects women, infants, and children. It affects the programs that are developed. It affects the policies that are put in place in states and in tribes and territories and localities. It affects how women, infants, and children receive care, how they access care. It affects how these programs are developed for them.
It's very crucial that this program continues to do what it has done for 25 years.
I think we also have an opportunity to now integrate in the area of chronic disease as well as other areas so that we're not just looking at areas around pregnancy and childbirth, but the health of women before, during, and after pregnancy, as well as the health of families in the level of a community.
I think partnership is more important than ever.
When we think about the work that we do in federal agencies, the more opportunities that we have to do things together, I think really strengthens it. And The MCHB and CDC collaboration in maternal child health epidemiology, I think, has been a shining example of federal collaboration, and it's really exciting to see. And together we've been able to work with states as well as tribes and territories to really strengthen the work of improving the health of women, infants, and children.